Today we're going to talk about tracheostomy. So we'll deal with the definition, the functions of a tracheostomy, indications, the types of tracheostomy, the technique, the different types of tubes, postoperative care, decannulation, complications, and other procedures that replace or can be used as an alternative to tracheostomy. So what is a tracheostomy? A tracheostomy is a procedure of making an opening in the anterior wall of the trachea and converting it into a stoma on the skin surface. What is the function of a tracheostomy? First function is it can provide an alternative pathway of breathing. So whenever there is an obstruction in the upper airway and we are unable to breathe air through the upper airway, then a tracheostomy provides an alternative pathway for breathing. Second, it improves the alveolar function. In certain respiratory conditions, the alveolar ventilation is improved by decreasing the dead space by 30 to 50% when you create a tracheostomy. Third, it protects the airway. When you use a cuffed tracheostomy tube, the tracheobronchial tree is protected against aspiration of the pharyngeal secretions, especially when the patient is in coma, or aspiration of blood, especially in the case of injury involving the pharynx, larynx, or maxillofacial area. And the fourth function is it permits removal of tracheobronchial secretions. So when the patient is unable to cough, especially in patients who have head injury or coma, or the cough is painful, as in the case of chest injury, fractures of the rib, then suction can be done via the tracheostomy to remove the secretions. So these are the four primary functions of a tracheostomy. So what are the indications or conditions in which a tracheostomy is indicated? So the first one is respiratory obstruction. Conditions that result in respiratory obstruction can be helped or the treatment can be aided with the help of a tracheostomy. So infections like croup or acute laryngotracheobronchitis, acute epiglottitis, diphtheria, Ludwig's angina, quinsy, retropharyngeal abscess, parapharyngeal abscess, trauma to the larynx and the trachea, trauma due to endoscopy, fractures of mandible or maxillofacial injury, tumors, benign and malignant tumors of larynx, pharynx, upper trachea, the tongue, and the thyroid, foreign body of the larynx, conditions that result in laryngeal edema, irritants, gases, chemicals, steam, allergy, bilateral abductor paralysis, congenital anomalies like a laryngeal web or a laryngeal cyst or a tracheoesophageal fistula. So all of these conditions, a tracheostomy is indicated, and the primary cause is respiratory obstruction. Now, second indication is retained secretions. So secretions get retained when the person has an inability to cough. Example, coma due to a head injury or a stroke, paralysis of the respiratory muscles due to spinal injury or polio or Guillain-Barré syndrome, spasm of respiratory muscles due to tetanus or strychnine poison. Now, painful cough can also result in retained secretions. Chest injury, rib fractures, pneumonia. Aspiration of pharyngeal secretions can also result in retained secretions. So, bulbar polio, polyneuritis, bilateral laryngeal paralysis. So, all of these conditions result in retained secretions, and then a tracheostomy becomes indicated. A third is respiratory distress or insufficiency. Chronic lung conditions like emphysema, chronic bronchitis, and atelectasis. Now, the fourth indication is for intermittent positive pressure ventilation when it is required for more than 72 hours. So, for the initial 1 to 3 days, an endotracheal intubation may be enough, but when it is required for more than 3 days or long term, then a tracheostomy is indicated. Now, the fifth indication is for the purpose of administering anesthesia. So whenever endotracheal intubation is difficult, especially in the case of tumors involving the laryngopharyngeal area, then a tracheostomy has to be created and then anesthesia given so that the procedure can be done. So these are the indications for a tracheostomy. Now, what are the types? So, we have the elective type and the emergency type. Then you have the permanent type, and then you have the newer percutaneous type. So, elective tracheostomy. It's a planned procedure. There is no rush. There is complete airway control at all times. You intubate the person, that is, you do an endotracheal intubation, and then you give a local or general anesthesia. So, it has got two types. It can be therapeutic or prophylactic. Therapeutic means to relieve the respiratory obstruction, remove the tracheobronchial secretions, or to give assisted ventilation. Prophylactic means to guard against anticipatory respiratory obstruction or aspiration of blood or pharyngeal secretions in the planned extensive surgery of tongue or mandible, etc. So either you can use it as part of the treatment, or you can use it as part of prevention of complications while you do a major surgery involving the head and neck region. Now, the second type is emergency tracheostomy. This is done when airway obstruction is complete and acute, and there is an urgent need to establish an airway. And at that point, an endotracheal intubation or a laryngotomy was not possible. Then an emergency tracheostomy is indicated. Permanent tracheostomy. This is done in case of bilateral abductor paralysis or laryngeal stenosis. In laryngectomy or laryngopharyngectomy, the lower tracheal stem is brought to the surface and stitched to skin. So it is also done in certain malignancies involving the larynx, where the entire laryngectomy is done and now the oral cavity does not communicate to the lungs via the trachea. Instead, the lower end of the trachea is brought out permanently. So that is one of the indications for a permanent tracheostomy. Now, fourth one is the newer variety known as percutaneous tracheostomy. The tracheostomy is done percutaneously using guide wire, dilators, and tracheostomy tube. So, what are the parts of a tracheostomy? So, a tracheostomy tube is a curved tube that is inserted into a tracheostomy stoma into the trachea. A commonly used tracheostomy tube consists of three parts. You have the outer cannula with the flanges or the neck plate, then you have the inner cannula, and then you have an obturator. So briefly about the three parts. The outer cannula is the outer tube, and that holds the tracheostomy open. The neck plate extends from the sides of the tube and has holes to attach cloth ties or velcro strap around the neck. The inner cannula fits inside the outer cannula. It has a lock to keep it from being cuffed out, and it is the one which is removed regularly for cleaning. The obturator is used only to insert the tracheostomy tube. It fits inside the tube to provide a smooth surface that guides the tracheostomy tube when it is being inserted. So the tubes can be made of metal or plastic. It can be cuffed or uncuffed. It may be fenestrated or not. The common ones previously used are the Fuller's tube, the Jackson's tube, Shelley's tube. So you can see the three parts over here. That's the outer cannula with the two neck flanges. This is the inner cannula or inner tube, and this is the obturator. And this is the Fuller's bivalve type. You can see the bivalves. And this is the newer variety, which is the disposable cuffed type. You can see the cuff over here. You can see the cuff over here. Again, the hole for keeping the neck strap. All the parts are seen. So what's the technique for a elective tracheostomy? So you have to induce general anesthesia and then do the endotracheal intubation. The patient is positioned with the pillow under the shoulders so the neck appears is extended. A transverse incision 5 cm long is placed 2 finger breadths above the suprasternal notch, and this is used in elective cases. Now you can also use a vertical incision in the midline of the neck from the cricoid cartilage to the suprasternal notch, and this can be used in emergency as well as elective. So this incision here, you can see the transverse incision. The placement is almost the same as for thyroidectomy, except for the length of the incision. Now the vertical incision that is used for emergency or elective tracheostomy as well. So once the incision is placed, you dissect the subcutaneous plane and the investing layer, you open it, then you see the strap muscles which are also separated in the midline and retracted laterally. Then you see the thyroid isthmus, it is displaced upwards, and if need be you can divide it between clamps. In most cases it can be just displaced up using a thyroid retractor or using an instrument that is suited for it. Then few drops of 4% lignocaine is injected in the trachea to suppress the cough, which is likely to happen when you incise the trachea. The trachea is fixed with a hook and opened with a vertical incision through the second and third tracheal ring. This vertical incision is then converted into a circular opening by taking off a piece of the trachea and removing it out. The tracheal dilator is inserted through the tracheal incision. Tracheostomy tube of appropriate size is inserted and the dilator is then removed. Hemostasis ensured, tracheostomy tube is secured with tapes. The gauze dressing is placed between the skin and the flanges of the tube around the stoma. So this is how it looks like. You put the vertical incision in this case, you open the investing layer, you separate the strap muscles laterally, then you retract the thyroid isthmus upwards, then you make an incision on the tracheal rings. So you can make you can do a jog flap tracheostomy, or you can do a vertical incision. That's the one commonly done. And then use the dilator, then pass the tube, and then remove the dilator. So this is how it looks like, how the tracheostomy tube goes through. It goes through the stoma and in through the tracheal opening. So there's another type of tracheostomy based on the level of the opening you have made in the trachea. If it is done above the level of the isthmus, then it is known as a high tracheostomy. If it is done just like the way we described, that is by retracting the isthmus, and you make the opening through the second, third or fourth tracheal ring, it would be called as a mid tracheostomy. And if it goes below the level of the isthmus, it is called a low tracheostomy. Generally, the isthmus lies between 2, 3 and 4 tracheal rings. So this is how the end result will look like. You can see the hyoid bone, thyroid membrane, thyroid cartilage, cricoid cartilage and ligament, and then you can see the tracheal rings. In this case, it is a mid tracheostomy picture. You can see the tracheostomy tube going through the third and fourth tracheal rings and the neck strap on either side. So this is how it looks in real. This is how you can see how the local is given. Now here what we are seeing is the percutaneous tracheostomy technique. So again the local is given, you can see the technique here. So again the first picture, injecting the local direct from outside, then you inject the needle with the guide wire, then slowly the needle is removed and the guide wire remains, and you give progressive dilators which pass through the guide wire, and then finally you make it enough dilated so that you can place the percutaneous tracheostomy tube. So it's about progressive dilation and insertion of tracheostomy tube. So it can be done bedside and using local anesthesia. Now the post-operative management. So it requires constant supervision. You must look for bleeding, displacement or blocking of the tube. So whenever the patient has to communicate, since the sound is gone because you have bypassed the oral cavity by the tracheostomy, he can be given a paper and pen for communication. And daily wound care is a must because secretions will be seen daily. Second is periodic suction. It's required every half an hour or so depending on the amount of secretions, and sterile catheters must be used for suction. And it's important that when you insert the catheter, it can be just placed simply. While you withdraw it, the suction must be applied. The third one is proper humidification. By use of a humidifier or ultrasonic nebulizer, few drops of normal saline or ringer lactate may be instilled in the trachea every 2 to 3 hours to loosen the crus. And the fourth is the care of the tracheostomy tube. The inner tube must be removed and cleaned regularly. Outer tube should not be removed for first 3 to 4 days, but thereafter even that also must be cleaned. The cuff tube must be periodically deflated to prevent pressure necrosis of the trachea. Along with this, chest physiotherapy, and then when the time comes and when no longer the tracheostomy is required, then you can initiate decannulation. And make sure the room is always a warm ventilated room. So what is decannulation? The tracheostomy tube should not be kept longer than needed. Tracheostomy tube is plugged and the patient is observed. If the patient can tolerate it for 24 hours, the tube can be removed. The equipment for re-intubation should be available when you attempt a decannulation, because once you close the tracheostomy airway, the person will go in distress if the upper airway is not patent. If it is patent and there is no airway obstruction, then the tracheostomy will not be required for breathing. The wound is daily dressed and the patient is observed. So what are the complications with the tracheostomy? So the immediate complications or the intraoperative complications is the hemorrhage or bleeding, injury to the esophagus, injury to the rectal nerve, injury to the apical pleura, which is right close to that area, which can result in pneumothorax, and injury to the common carotid artery. So all the vital structures can undergo injury during surgery. The early postoperative complications again is hemorrhage, which can be delayed, reactionary or secondary. There can be a fall in PCO2 resulting in apnea, subcutaneous emphysema, pneumomediastinum or pneumothorax, infection, tracheitis, tracheobronchitis, displacement of the tube and blocking of the tube. Now the late postoperative complications include again hemorrhage due to erosion of a major vessel, laryngeal stenosis, tracheal stenosis, tracheoesophageal fistula, a persistent tracheocutaneous fistula, a difficult decannulation, tracheostomy scar-related problems. So these are the various complications that we see in a regular tracheostomy. Now what are the other procedures that we can do other than a tracheostomy? So we can always go for the most important, the easier one, that is known as endotracheal intubation. It's a more rapid method to establish the airway. Larynx is visualized using a laryngoscope, and then the endotracheal tube is inserted into the trachea. No anesthesia is required. Nasotracheal intubation may also be done if the patient has severe trismus or mandibular injuries, because of which the oral cavity cannot be used for the entry of the tube. Now second method is laryngeal mask airway or LMA. It's a wide bore airway with an inflatable cuff at the distal end. So it also provides a clear and secure airway if laryngotracheal airway is clear. So it doesn't go deep and you can only take care of the upper airway. So you can see this now. The first picture over here, this is the endotracheal tube, and this over here is a laryngeal mask airway. You can see how it goes and how deep it goes. It only goes up to the area of the larynx. Now then you have the cricothyroidotomy. It's a procedure for opening the airway through the cricothyroid membrane. Again the patient's head is positioned and the neck is extended. The area between the lower border of the thyroid cartilage and the cricoid cartilage is palpated. That's the cricothyroid membrane area. Vertical skin incision is placed, dissected up to the cricothyroid membrane. 1 cm transverse incision is made through the membrane and the scalpel is twisted through right angles to gain access to the airway. A small tracheostomy tube can be placed, and later on a proper tracheostomy has to be done, as this is always associated with the risk of perichondritis, subglottic edema and laryngeal stenosis. So it's ideally used as an emergency procedure when you are unable to do an endotracheal intubation or arrange for a tracheostomy. So this is how it looks like. You can directly make a small cut, then cut through the trachea, cricothyroid membrane, and twist it a bit so that you can allow the entry for the tube. So you can see it here. This incision over here is a cricothyroid membrane. You make a small space and you insert the tube. So saying this, I thank you.